Good evening, everyone, and thank you so much for taking time tonight to watch the Medi-Helpz, CHL.M.S Medi-Helpz Educational Wednesday series. This evening, we were fortunate to be blessed with Dr. James Chamberlain, who's been in the pediatric realm for over 30 years. Our topic tonight is pediatric sepsis. And so, as I say every Wednesday when we do the videos, what I say every Wednesday is that we're all here to learn. We're all here to be educated, because how else can patients become uh, engaged and empowered if they're not first educated? And so I'm the first one to tell you, I do not know everything. I don't have all the answers. Heck, I don't even have half the answers. But what I do know is that as a community of patients, of which I am one, the one way that we will move forward and have a sustainable growth and understanding, and be able to remove some of the negative words that are used very often when we're not understanding and we're just not following through, is to be educated. So with that being said, I am going to go ahead and do like I do every Wednesday. Sit back, enjoy the conversation, enjoy being educated by our honored guests. So with that being said, Dr. James Chamberlain, would you please go ahead and introduce yourself and let us know all about what is pediatric sepsis?
Sure. Thank you. Is the sound okay for you? Can you hear me?
Yes.
Great. So my name is James Chamberlain. I've been working at Children's National since 1988, so 35 years. And I only do pediatrics, and I only do the emergency department. So sepsis is sort of our thing. That being said, sepsis is a difficult thing to detect. Once you detect it, there are good treatments. But I wanted to go into a little bit about why it's hard for us as physicians, medical providers, to detect sepsis. And then I'll go into some strategies that you can adopt as parents and patient advocates and patients yourself, if you think sepsis might be a problem. So I have to introduce you a little bit to how we do diagnostic testing. So this is a perfect diagnostic test. All the patients that are healthy have this value of whatever the test is over here on the left, and all the patients with disease have this value on the right. Perfect separation of healthy from disease. This doesn't happen in real life. The only thing I could think of that might fit here is if this was a heart rate of 0 and this was a heart rate of 60, all these patients would be dead and all these patients would be alive. Even that's not perfect because of brain death. But anyway, most diagnostic tests look like this. Healthy patients have a normal distribution of values over here on the left, and then patients with disease have a normal distribution of values, but it's shifted. So you think about blood pressure. If you have a high blood pressure, you're over here on the right. If you have a normal blood pressure, you're over here on the left. And the issue is the area of overlap here. So let's say I pick this cut point of a diastolic blood pressure of 85, and I say that is high blood pressure. Well, you're going to miss some people with disease who have a blood pressure less than 85, and you're going to call some people disease who have a blood pressure of over 85. So there's this overlap area here, this gray area where people may or may not have disease. And so you see the farther out your blood pressure is, if you get up to a blood pressure of 110, then you're clearly in the abnormal range, okay? But in this gray area, you may or may not have disease. This is what sepsis looks like. So it's even worse overlap. Healthy patients are here on the left, and patients with disease are here on the right. And you can look at any particular test, heart rate, respiratory rate, blood pressure, white blood cell count, inflammatory markers, And there's this tremendous overlap. So it's very hard for us as clinicians to distinguish between patients who just have a routine virus and a regular infection versus patients who have early sepsis. We use triggers in our electronic health record. If you have a certain heart rate, a certain respiratory rate, if you have a underlying immunodeficiency disease like cancer, that gets you points. And those triggers will tell us, watch out, this patient may have sepsis. The problem is that they're wrong 90 to 92% of the time. In other words, they trigger too easily. You don't want to miss anybody with sepsis, but every time that trigger goes off, 9 times out of 10, the patient does not have sepsis. So given our current state of knowledge and our current triggers, this is not a helpful approach. There's too many false alarms. And we're trying to work to fix that. So here's the proverbial needle in the haystack. Why can't we detect sepsis earlier? In children, sepsis is very rare. It's roughly 1 in 300 patients with fever. So for every 300 patients I see with fever, 1 of those may have sepsis. Sepsis is just an exaggeration of your normal immune response. Your normal immune response is to have a fever, to get your heart rate up, your respiratory rate up, your white blood cell count goes up, and that's normal. But sepsis is an exaggeration of that when things get out of control. And the immune system only has a finite repertoire of things it can do to attack an invading virus or bacteria. So sepsis looks a lot like just routine response to fever. Early sepsis looks like every other child with fever, as best we can tell with current science. So you almost have to wait until they show late signs of sepsis. Children can't tell us what's wrong as well as adults. They can't tell us that their head hurts or they feel nauseous or their stomach feels queasy because they don't have that vocabulary. And not sure if you're aware of this, but adults tend to decompensate faster than children. Children have somehow some miraculous reserve where they continue to look good, and then all of a sudden they crash. So that makes it hard to detect them earlier. Now, by the time you get to late sepsis, when they start to crash, that's easy to detect. We can all easily detect late sepsis, but by that point it's late, and sometimes it's too late. So I just created this little checkbox, little chart of early sepsis versus other types of infection that we see commonly in pediatrics. Adenovirus is what we're seeing right now with pink eye, ear infection, sore throat, causes pneumonia. Influenza, you're familiar with flu. RSV causes wheezing in babies. Human metapneumovirus causes pneumonia. Rhinoenterovirus causes pneumonia. All of these things overlap tremendously. They all give you the same symptoms with the exception of shaking chills. You probably don't see that in RSV, human metapneumovirus, and rhinoentero. But in all these other conditions, there's complete overlap with early sepsis. So early sepsis looks just like every other viral infection that kids get. So what's the scope of the problem? At Children's National, we're one of the larger emergency departments in the country. Last time I checked, we were number 5. But we see about 328 patients every day between our 2 emergency departments. Many of these have serious underlying illnesses like cancer and other immune deficiency diseases that make them more likely to get sepsis. The average healthy child is unlikely to get sepsis. More than half the cases occur in people with these underlying chronic illnesses.
Dr.
We only see.
Before you go further, I do want to ask you something.
Yes.
When you say that the children, many have serious underlying illnesses like cancer and immune deficiencies, is that something that would be a family, like a family history thing with them having these underlying conditions? So say if the dad or the mom had, this is more susceptible for the children to have it as well?
No, these these are something that the parents would know about.
Okay.
So these are diseases where the parents would come in and say, my child is being treated for cancer, and they get chemotherapy drugs, and that weakens their immune system.
Okay.
So that's the kind of thing I'm talking about. But the point I'm trying to make is that at Children's National, because we're a large academic children's hospital, we see the really sickest kids being treated for the sickest conditions. At a normal emergency department or urgent care center, they don't see anywhere near this kind of number of patients with cancer and immune deficiencies. So even with all these seriously underlying diseases, 328 patients a day, we only suspect sepsis about 1.2 patients per day. So about one patient a day, 300 or 400 patients a year, where we think they have sepsis, give them antibiotics, treat them, admit them to the hospital. Now, of those, the most common thing is we never find the reason. We don't know why they had sepsis. 15% have a bacteria, 16% have a virus. So even, bacteria is the one we can treat with antibiotics. Viruses we can't treat, and viruses are pretty common. Now, try to extrapolate this to community emergency departments in the United States, not large children's hospitals. 2/3 of community emergency departments see less than 15 patients a day, pediatrics. So that means the average doctor that you see in a community emergency department will not have seen sepsis for months or years in a pediatric patient. So they won't be tuned into it. They may not recognize it because they just don't see it. Now, the same is true with EMS. These are the paramedics and EMTs that pick you up in the ambulance. We did focus groups with paramedics to find out what they thought about pediatric sepsis. Here's a typical quote: "Our numbers are pretty low, so I'm not confident that we could detect pediatric sepsis at this time. It's definitely nerve-wracking taking care of kids. It's not something we do every day. IVs, for example, we start in adults 5 or 10 times a day, but in pediatrics, it's rare. The chances of a pediatric call are 5%, and even less than that are really sick, and having a chance of a septic patient is very small. Here's one, 9 months old. I wouldn't recognize their normal vital signs, their normal heart rate and stuff. Here's the difficulty: the child who's crying and has a high heart rate. Do they have a high heart rate because they're crying, or because they're infected with a sepsis problem? So here's one. I think I probably wouldn't recognize a septic child if they're critically ill. Sepsis is one of the last things I'm thinking of. And then here's one about possible medication errors. We don't have specific medications for kids, so we have to mix them, and it leads to the possibility of errors. So this is from pre-hospital, because that's the work we're doing. But I suspect if you went to community emergency departments that only see 15 or 10 pediatric patients a day, you get some of the same answers from the doctors at those emergency departments.
Now, is there any way that because I know in the community we have, especially in the communities, the underserved and marginalized communities, right? You just said a lot of times sepsis can be tied to bacteria. Well, one of the social determinants of health is air quality and the environmental factor. And so the environmental factor is very much a problem in underserved and marginalized communities. And so is there like any type of, looking down the road, is there anything that would say, okay, well, let's put some training into these communities so that they'll know, should they see it, they'll know what it looks like? Or is that something that's just like an afterthought or something that you put on a wish list?
Yeah, so the good news is that most of the major children's hospitals in the country are in underserved areas, and that's not by accident. Children's National is in an underserved area of Washington, D.C., And we opened a satellite emergency department in wards 7 and 8, the poorest part of our city, for that very reason, so that we could reach disenfranchised patients.
Okay.
And that's true throughout the country: Milwaukee, Chicago, maybe not Boston, but Philadelphia for sure, Cincinnati. So the large academic children's hospitals are already treating the underprivileged and the disenfranchised. So that's good news. So you're going to get great care if you come to our hospital
Okay.
or one of these other hospitals. As far as educating parents better, we could do a much better job. And I know Johns Hopkins has community health workers that go out into the community and work with parents. And that's a great program and something that should be emulated. So I'm not giving up on I'm optimistic about the ability to detect sepsis sooner. First of all, we're using machine learning techniques, advanced computer techniques, to try to detect and refine our sepsis triggers. We're looking at biomarkers, those are different enzymes in the blood, different chemicals in the blood that might help us distinguish sepsis from non-sepsis. Overall, in the last 10 years, there's been a much more broader national awareness of sepsis and lower thresholds for detecting it. So everyone is keyed into it now and is looking for sepsis and plans to try to find it and treat it earlier. And then when we do detect sepsis, our critical care colleagues in the hospital are much better at treating it than we used to be. We've learned a lot in the last 20 years on how to treat critically ill kids, and the treatments just keep getting better and better. So what can you do as a parent? So if possible, I would strongly recommend that you go to a pediatric specialty hospital or a pediatric urgent care. So if you were going to have spinal surgery, you wouldn't just go to a general surgeon, right? You'd go to a spinal expert.
Correct.
If you were going to have brakes put on your car, you wouldn't go to a muffler specialist, right? You go to a brake specialist. If you're going to take care of your child, take them to a child specialist. Take them to a pediatric urgent care, PM Pediatrics. There's other ones out there. Or a pediatric specialty hospital like Children's National. Don't take them to just a random community emergency department.
Now, I do have a question in reference to that. For the people that are watching, watching the video, how would they be able to find a pediatric? I mean, of course, you will send Children's Hospital. Okay, that's a Children's Hospital, but the pediatric urgent cares, how would you be able to decipher which is a pediatric urgent care and which is not a pediatric urgent care?
Sure. If you just go on Google and search pediatric urgent care, you will find it. If you, I think a big red flag I would not go to, if you look up urgent care and it says we treat patients of all ages, you're likely to get, a general medicine doctor or even a psychiatrist who's just doing some moonlighting and does not specialize in pediatrics. So look specifically for pediatrics. The other thing you can do for your hospitals, I know it's not feasible from everywhere in Maryland to come to Washington, D.C. or to Johns Hopkins in Baltimore to see a pediatric emergency department. But look at the volume of patients at your emergency department. And if they see more than, I'd say 10,000 or 15,000 children a year, then I would feel comfortable that they know what they're doing taking care of kids.
Okay, thank you.
Yeah. Now, here's where we really depend on a parent's judgment. Parents know their child better than we do. We only get to meet you for an hour or so in the emergency department. We can always observe you longer if we're concerned or if you're concerned. But you should know the signs of serious illness: shortness of breath. If someone is working hard to breathe, they should go to an emergency room right away. If they have altered mental status, so that means acting dazed, confused, or just out of it, that is very concerning to us. That means something serious is wrong. Dehydration, that means no urine in 10 hours. That can occur for many reasons: vomiting, diarrhea, uh, sores in the mouth that prevent children from drinking. But in the setting of a fever, dehydration is a very serious thing and needs to be attended to right away. Diffuse bruising. So it's normal for toddlers to have bruises on their shins and sometimes on their arms when they fall. But if you start seeing bruising on the abdomen or chest or on the upper legs or on the face, that's very concerning. That something's wrong with your clotting mechanism in your body, and you should be seen right away for that, especially if there's a fever going on. And then, children respond dramatically to Tylenol or ibuprofen. So ibuprofen or acetaminophen, they get dramatically better. So if your child is feeling kind of punky, they have a fever, you give them some ibuprofen, they're up smiling, playing, they don't have sepsis. They're doing great. If they don't get better with the ibuprofen, I would have them checked out. Don't accept glib answers from doctors or PAs who are not well versed in pediatrics. If they say things that don't make sense to you, it sounds like they're not well versed in pediatrics. They don't see that many kids. Ask for a second opinion, or ask to talk to a hospital that sees kids, and then advocate for your child. You say things like, "I'm worried. Her condition really scares me. I don't know what's going on. I don't feel comfortable taking my child home like this." Those are trigger words for all doctors that, okay, parent is worried. I should take this seriously. I need to investigate this a little bit more. Now, what you should watch for, I think I covered most of this. Altered mental status, so dazed, confused, out of it. Rapid breathing, rapid heart rate. Dehydration, that means no urine in 10 hours. Unusual bruising. And I just put these asterisks up about the rapid breathing and rapid heart rate. It's normal to breathe fast and have a rapid heart rate when you have a fever. But what you do is you treat it with ibuprofen and give it a half an hour to an hour. Once the fever has come down, the rapid breathing and rapid heart rate will come down. If they don't, then you should be worried. So again, rapid breathing, rapid heart rate are okay with a fever, but once you take care of the fever, those should go away. And then this is sort of a slide about, this is a hierarchy of effectiveness for how things are effective in medicine. And the highest, the most effective things are systems-based changes where you force things to happen or you automate things with a computer. We're not there with sepsis yet. We don't have good enough tools yet. Where we are with sepsis is sort of in the middle here. We're part system-based and part people-based. We try to remind people, we do checklists, we do double checks, we try to simplify things, and then of course we standardize our order sets. But I'm hopeful. I mentioned machine learning, and I mentioned computer models and better detection. I think in the next 10 years, we may be able to get to this highly effective systems-based approach, which will prevent further cases of missed sepsis. So with that, I'll stop and I'll ask questions, and I'm happy to recycle back through slides if people have questions about specific things on the slides.
And Dr. Chamberlain, I am not seeing any questions that have come through. However, what I would like to know is if it's possible that you can actually send the slides over to the foundation so that we can have them, because this is helpful information for us to have. Sure. Should we be asked about, hey, I was listening, but I didn't catch it. Do you have a copy so that we can share? Because once again, we cannot look at a patient to be empowered and engaged, whether it's with their own health or with their children's health or grandchildren's or nieces or nephews or whoever. we can't do it if we're not educated. And if we don't have the proper tools to be educated on and with, then, empowering us and engaging us as a patient is really like a mute point. It's like a talking point and not a sustainable, actionable plan, because you have to educate before you can look for anything else. So, on behalf of the CHLMS Medi-Helpz Foundation, myself, as well as my board, I want to say thank you so much for taking the time out tonight of your busy schedule. I also want to put this disclaimer out here. These are facts that are being given to you as a patient from a doctor who is well skilled and well versed in the area of pediatric emergency medicine, sepsis. He's a doctor that's scheduled, really a senior subject matter expert, I should say. But that does not mean you don't listen to your doctors. That doesn't mean you sit silently by the side and just let anything and everything happen to you or your child, or, especially with summer coming up and it getting warmer outside and the kids being out, and, maybe you'll have some children at your house. This is a good time for you to say, let me be an advocate. Let me open up my mouth and say something when I don't know, so that I'll know what it is that's going on. If you get brushed off or gaslighted, and yes, gaslight happens to all patients, especially those who can't speak up for themselves or who are with someone that's not speaking up for them, it can happen. So what you're going to do is you want to make sure, especially when it comes down to our youngest of patients, that you as the adult in the situation are speaking up, asking questions, and letting it be known that you are happy with the services or you're not happy with the services. So with that being said, Dr. James Chamberlain, thank you so much for taking time this evening. And if anyone is viewing this now or has questions and it's like, how can I get in touch with Dr. Chamberlain? I'm not going to give you his personal email address, but if you send me an email address to contact us at Medi-Helpz.com, I will make sure to send it along, and then I'll let him make the decision on whether or not he has the time to actually personally address you, or he wants to send me some information so that I can get it to you. So, Dr. Chamberlain, thank you so much again. I certainly appreciate it. And once again, I know my board appreciates it. And I know the patients appreciate it. Thank you so much.
All right.
Have a good night.
Thank you.